Good afternoon and good morning, whatever time it is in your part of the world. Welcome to our fourth seminar in this global series, looking at the impact of COVID-19 pandemic on mental health services. And this evening's program, we're focusing on Denmark with a little bit of an overview of all the Nordic countries in terms of impact on their healthcare more generally. But our real focus tonight is going to be on the mental health services and their response in the wonderful country of Denmark. First of all, my name's John Mendoza, and I'm director here at Connecticut, and also have some adjunct appointments at both the University of Sunshine Coast and Sydney University. And my co-host is Professor Luis Salvador Carrilla, who's the head of the Centre for Mental Health Research, and very well known throughout Europe for his leadership in many of the integrated care projects across the European Union. On behalf of Luis and myself, we'd like to welcome you all to this seminar tonight. And before we begin, I'd like to acknowledge the traditional owners of the country on which we're sitting, which is known as Gubbi country. It's about an hour north of Brisbane in southeast Queensland, and in Canberra the traditional owners being the Ngunnawal people of that part of what is now known as New South Wales. But acknowledgement to all First Nations people around the world, because they have treasured the land on which we're all meeting for many generations. So if I just start with a bit of an overview of our agenda tonight and the way we've been running each of these forums, we'll follow pretty much the same format tonight. We'll do a quick guide to Zoom for those of you who might have been on holidays or maybe on a cruise ship where you couldn't access Zoom. But I think everyone in the world's converted to Zoom very quickly in the last few weeks. And we'll do a little bit of a run through that. We'll talk also about the fact that tonight we are recording the presentation, and we will be posting that both on the, sorry, I just clicked ahead there. We will be posting those recordings on the Centre for Mental Health Research and the Connecticut websites and providing free access to them. Luis in a moment will talk a little bit about the purpose of the global seminars, an overview of managerial epidemiology and its emergence in terms of health logistics planning. I'll give a quick overview of the situation here in Australia in relation to COVID-19, and then we'll hand over to our guest tonight, Dr. Michael Rasmussen from Central Region of Denmark. He's the head of Psychiatry and Social Services, which I think is remarkable in itself, Michael, that those two, if you like, components of public services are joined together. I've got Helen's presentation. I don't know how I got that. Helen Gillespie, of course, was our guest on Tuesday night, but it'll be your presentation, Michael, not Helen's. And then we'll have question and answer and close for the session. So you'll see, just before I hand over to Luis to explain the purpose, you'll see that there is a chat box down in the bottom right-hand corner of your screen. If at any time you want to put a question in there, please do so. We won't stop Michael during his presentation. We'll get to the end of that and then we'll come to the questions. I'll try and group the questions so that we follow some sort of theme. But if they're all over the place, then we'll proceed pretty much in order. Try and keep your question in the chat box succinct and as clear as possible in terms of what you're really trying to seek some clarification on. Luis, if I can hand over to you.
Thank you very much, John, and good morning or good evening, Mikkel, there in Denmark. Good morning. John was saying the purpose of this webinar series is to get knowledge of what's happening around the world for Australia and understanding things in advance by just knowing how other countries have been facing the problems of the COVID-19 epidemics. This is part of a new approach to epidemiology, which is called managerial epidemiology. It's the use of data and decision analytics to inform our policies. And last week, in the last seminar, we just before heard our government just explaining how models can inform us on the evolution of the COVID-19 epidemics. And today there was a very interesting paper at the British Medical Journal on the role of the different modeling techniques and how they can be combined and what are the problems, how can really advance our knowledge in this area. So we are very fortunate to have you here, Mikel, and to get some knowledge of what's going on in the Nordic countries, and particularly in Denmark, that it's one of the benchmarks of how to cope with the COVID-19 epidemics in Europe. Thank you.
So if I just give a brief overview of the situation here in Australia, and I think like presentations we've had certainly to date from all of our guests has really highlighted that there are very significant regional differences across different countries, even relatively small countries in geographic size like Italy. There are very significant differences in the regions. In Australia, we passed 6,000 cases of COVID-19 today and over 50 deaths. I haven't been able to update this during the day, so if these figures have now been superseded, I apologise for that. But I think one of the important things in all of that is the very small number of people that are actually in hospital. And this is total Australia-wide, it's not one jurisdiction. And these are acute patients, but there is a significant number of people also in hospital in the home, acute care in the home. In South Australia, I have access to those figures, and about the same, or in fact, sorry, double the number of people are receiving hospital in the home to those that are actually in the inpatient unit at Royal Adelaide. But relatively, it's a small caseload that Australia has at the moment. Since yesterday's situation report, we've had 105 additional cases, and we've been, I'll show the daily count and the way that's tracked down significantly. There have been about 600 or more cases from one ship. We were talking about cruise ships in the preamble tonight. The Ruby Princess is becoming rapidly infamous in this country, with more than 11 deaths now, and reportedly over 200 of the ship's crew now infected. Other cruise ships have also been implicated in the caseload in Australia, and 66% of all cases are related to international travel. And the closure of our international borders has been a real factor in driving down the number of cases on a daily basis, plus the requirements for isolation for people returning from overseas. The median age you can see there, and the median age for COVID deaths is in the high 70s. I wasn't able to get an accurate figure on that before posting this update this morning. And you can see our rate of testing is certainly in the higher group of nations around the world in terms of 12,000 tests per million residents. If we have a look here, I'll just move the chat box or the participant list over here. You can see we had this rapid escalation through the middle of March, and we were certainly on track to be around 15,000 cases today if we'd maintained that trajectory. we would have been somewhere up here, or in fact higher. But instead, through much more stringent social isolation and so forth, Australia has tracked down pretty dramatically in the last week. And some jurisdictions have recorded very few cases altogether. The state-by-state scenario, you can see there, the bulk of cases in Australia are in the most populous state, New South Wales. But to be fair to New South Wales, it's also the gateway for most cruise ships and also international arrivals through Sydney Airport. Victoria's second most populous state, and it's got the second highest. Queensland, WA, South Australia, and then the smaller jurisdictions down here. So you can see here the overseas acquired makes up the majority in every jurisdiction, and then locally acquired, and then still some under investigation, but a very small number of investigations now being reported by the Chief Medical Officer. Mikhail, I'm going to hand over to you now, and if you can just let me know when you want me to proceed to the next slide. So I'd like to welcome Mikhail Rasmussen, physician, psychiatric consultant, mental health advocate, and a leader of a political party, which I found amazing in your bio, Mikhail. So I do expect to see you in the next series of Borgen. We get the Borgen series here in Australia, or Bolgen, I think is how you correctly pronounce it. And we all enjoy our Nordic television down under.
Okay, thank you very much. Yeah. In my presentation here, I will start with some facts from Scandinavia and Denmark, and then I will move forward to the central region of Denmark where I'm situated. I will mainly focus on the mental health system and also some views on the potential mental health crisis following the COVID-19 crisis. Yeah, you can call it the aftermath. But let's get started. The Scandinavian countries are known for their similarities in many aspects, culture, political, economy. But surprisingly, we see that there's an exception when we talk about the response to the COVID-19 crisis, where we see that Denmark and Norway has imposed more strict regulations and closed the borders, when Sweden has done relatively little in this regards. Yeah, you can skip this next slide. Just shortly to say that Norway, they tested a lot, and they have found like 5,760 coronavirus cases. And testing is mainly for a certain group of patients and health professionals who develop respiratory symptoms. Next. And just a short overview here is that to show the prevention measures and response in Norway, they closed all educational sport activities, cultural and event institutions, and closed the borders, of course, and they discouraged traveling only if strictly necessary, and avoid crowding places, social distances, and so on. The public transportation schedule run as normal. In Sweden, we see that there's a bigger raise of coronavirus cases, 7,200, and also a larger amount of deaths correlated to coronavirus. Here also, the testing is only for certain groups of patients and health professionals who develop respiratory symptoms. We see the curve is steep right now. If you look at the prevention and measures response in Sweden, they are actually operating normally for the most part. Schools from kindergarten to primary and even lower secondary remain open, and only the high schools and universities have now started to close down recently. The gathering can continue provided they are limited to 50 people. In Denmark, it's 10 people. Restaurants remain open, which is not done in Denmark, and only citizens aged 70 or over are encouraged to stay home, and the borders are open. So that's a different approach. If you look at Denmark, we have 4,600 cases and 187 deaths. It might have increased since I made this PowerPoint, but we also have a big amount of recoveries of the COVID-19. Tested until the 27th of March was 4,000, but the testing capacity is largely increased now in Denmark. Until now, it has been also a certain group of patients and health professionals who developed respiratory symptoms, but now they are also in the process of making testing to the general public because of we have getting more test equipment. In Denmark, it's very like the same in Norway, but the difference is has very clear stated that we should avoid crowded places, social distance with 2 meters, and no more than 10 persons gathering. And the police is keeping an eye on this, and they can give you fines if you don't follow the guidelines. And there's also an interesting part here is also that people can no longer visit institutions and with vulnerable groups like elderly and psychiatry patients, social services. There's no visits of family of patients. But otherwise, and we have closed down all not necessary functions in the society. So that's the short. But then you can ask yourself, why is there such a divide in strategies in countries who are very closely related? If you look at the case of Sweden, the government relies on the personal responsibility of the population. And there's also a very much an economical approach and a political approach. And then there's also a cultural approach in Sweden. The Swedes are good at keeping distance in general. Of course, the aim is to trying to curb the curve and as much as possible. So the limit of number of cases reported it can preserve the capacity of the healthcare system to the health crisis. And there is, Sweden did believe that the strict actions of Denmark are not based on scientific evidence. So that is their counter response when Denmark say the opposite to Sweden. Denmark, to compare, is from other hands, they had taken a rapid action, managed to slow the development of the pandemic, as so to speak, keeping on the green curve. So the healthcare system can follow and treats all patients who's in need. And they're right, not all measures have scientific evidence, but it has a major psychological impact on feeling safe. And of course, the same concern is to keep on the green curve so it doesn't explode and the capacity of the healthcare system cannot follow. The Danish people have a special trust and they follow the authorities concerning safety measures. And they also have another, there's a demographic and difference that the density population of Denmark is 137 per square kilometers, and in Sweden is 25. So Danish people are also less good at keeping social distances, and that's yes, that's also a reason why they have been more strict in the law about this. Denmark believes Sweden could face big numbers by not taking actions, and recently we have also seen that Sweden has also going to a more strict approach. That's a lot in the slides here, but if you see then Denmark and Norway, if you compare those two countries, because they're both have taken strict measures, but still in the latest numbers, it shows that the disease has killed 12.3 Norwegians per million inhabitants. In Denmark, the number is 3 times higher. It's 30.7 Danish per million inhabitants. And in Sweden, it was even higher again on 38.8. So why is there so big a difference? And there again, you go to the geographical and demographical differences. Also, there's some talk about that there's a time difference, that in Denmark, the initial infection came from abroad and maybe was starting spreading before even detected. And there's also been some outbreaks in elderly homes who also have maybe increased the numbers. And there again, there's a difference in population density. And in Norway, people are living far from each other. There's a longer distance to just go to the grocery markets and to meet each other. So there's natural causes also in the longer distance. So already before the lockdown, there was kind of social distance in Norway in comparison to Denmark. So maybe that is some of the explanations about the differences. Here you just see an overview in Europe, and you can see the difference between Sweden, Norway, and Denmark, and also in the rest of Europe, what they have done to deal with the COVID-19 and make the restrictions. And the slide here, the next slide, is just showing the differences as I talked about just before, the number of cases, deaths, and recurrence. Yeah. The next one you can jump ahead, and I can say that in Denmark, if you jump to the next one. In Denmark, we have some updated numbers now. The government has just announced during this week's press conference plans to gradual lifting of the coronavirus lockdown. And that means after Easter, that if things go as planned, they will reopen kindergartens and schools up until age 10, 11, as it takes the first step in this opening up. Still, churches, libraries, sport clubs, shopping centers will be closed until at least May 10. And the border control is still in place until at least May 10, until the new announcement will come. Restaurants, bars, cafes, hairdressers will remain closed until the next phase. We don't know when that is. And then they announced a ban on major events like festivals and so on, until that will remain in place until at least August. So that is the latest update from Denmark, actually from yesterday. Here is just an overview of in Denmark, we are divided in 5 regions, and we have like 98 municipalities. And here you just see the difference that, of course, East Jutland, that's where we have the second biggest city in Denmark. There's a big number of cases. In Copenhagen city, of course, there's also a higher density, so also a higher number of cases. But I'll not dwell with these slides and then move on. All the slides will be available afterwards, so if you have any question to that. This is just to see where you have the cumulative incidence of cases in Denmark. You see that is, yeah, we go on. And this is just to see the number of confirmed cases by age and sex. You see that there is a wide range of in the ages where it affects, and it's not only the elderly people, it's also other ages. You can see this. There has been different analyses about is there mostly men or women, but I think we cannot say anything totally exact about that yet. Here we see in Denmark that actually now we have a decline in number of deaths if you look at the numbers day by day. So we hope we keep that line. Then if you just hold on, and before I talked about this, I would say where I come from is the central Denmark region. And here I also have some slides, and that's what I'll continue to in the next slide now. Here we see a number of patients in respirators, and just here on the 7th of April, we saw actually a 25% decrease in patient admitted at the intensive care department in respirators in our region. Is the second column. But in general, you see that actually it's going down, the number of patients in respirators. And if you jump on to the next one, here, this is just number of admitted patients with confirmed COVID-19. You also see a tendency to, there's a decrease in number of admitted patients. And then this is the graphic here is showing the 5 regions of Denmark. Of course, the big yellow line is where we have Copenhagen, is that area. So of course, it's a higher density and also more people affected. But in general, we see a small decline when you look overall. Jumping to the next one, we have admitted at intensive care units. We see the same tendency, that is a decline in patient admitted in intensive care units with COVID-19. Okay. So far, so good. If you jump to the next one again, I'll go back to this after that. Sorry. No, the next. Yeah. Talking about Central Denmark region just shortly, we have a population of we have a population of 1.3 million people. We have 19 municipalities, and in the region we have 5 hospitals, 1 university hospital in Aarhus with 10,000 employees, and we have 4 regional hospitals. The psychiatric services are they are viewed as one hospital, but they are placed in the 5 different hospitals in the region, and around 3,000 employees there. And then we have the social services. Usually it's managed by the municipalities, but also the regional has a part. They have 8 specialized areas and 30 specialized residential accommodation and 2,000 employees there. Then you go 1 slide back. And this is just to talk about the mental healthcare system in Denmark in general. I will put a few words on this. In recent years, psychiatric care in Denmark has undergone a significant developments. The number of patients has grown, and treatment methods has changed considerably, both with regard to face-to-face contact with patients and with regards to increase in outpatient treatment. And subsequent, we have seen a reduction in number of hospital beds in Denmark. Between 2009 and 2014, the number of patients in contact with psychiatric hospital services increased by 28%. Partly it's due to a more open approach to people with psychiatric problems, and also partly due to a wider definition of psychiatric diagnosis requiring professional treatments. In the same period, the number of patients in outpatient care have also increased by 31%. To say something about this is the overall responsibility for the provision of psychiatric care. It lies with the regions and the municipalities. The regions are responsible for the psychiatric hospital services, as well as for the local psychiatry centers. The municipalities are responsible for the provision of social services and for alcohol and drug abuse treatments. So there you see that the differences. We have also private psychiatrists and the private psychologists. They have agreement with the region. And there's also the new thing in Denmark is we are making more cooperation between the municipalities and the regions in the local health centers, also with mental health problems, and also with psychiatry combined in those centers, but also with other somatic conditions. Yeah. The next is just to show the mental health care in the central Denmark's region. Of course, we have the political system, we have a regional council, and then under that we have direction, the directors of psychiatry and social, who is connected together. And if you see, the left part is mainly the psychiatry and divided on the different hospitals in the region. And then on the right, we see the social services. So, and as you maybe can see on the slide, it's a very specialized area. Is like with the brain damage and with autism, with ADHD, with young people, with criminality. It's with communication, education, and it also have a part with to help people with speech, hearing, and sight impairment, as well as other communication and motor handicaps. So it's a very broad line of services in the region. Yeah. If we look at the next next slide again, I will jump over this. This is just to show the amount of beds and occupancy. Yeah. If we look at the response of the mental health service of Central Denmark region to the COVID-19 epidemic, there we have some prevention strategies, and there's been a very various recommendations by the government, the Prime Minister, the Healthcare Minister, the National Health Board, and the police. And there's been a great work in trying to canalize this information downward the political system, to the hospitals, to the patients, to the family of patients, to the employees at the healthcare, to make sure everyone knows what's going on and what are we able to do and what can we not do. And there's been a very big amount of use of course, the official media, but also social media has been spreading around with all those things and on the websites. it was very important to address that psychiatry and social services is viewed as, one slide back, is viewed the critical function in the society, the individual level. So we maintain the same access to acute and planned activities. And one of the reasons, especially in the outpatients clinics, to keep the planned activities is to prevent worsening of psychiatry condition and avoiding hospitalizations of patients. There's also been made job banks for all healthcare personnel. And here is included medical students, nurse students, doctors who went on pension, coming back to this job bank. So in the case that everything explodes in the healthcare system, COVID-19 patients is infecting also healthcare personnel, we can actually take from this job bank people in to help treat patients. And several thousand of people have actually committed to this, but so far we didn't need it yet. So we hope we're not going to, but yeah. If you look at the service strategies in response to COVID-19, we have some guaranteed activities. As I said before, we have the same access to psychiatry consultation and same access to evaluation and hospitalization. In the social services, many of the direct contacts has been converted to telephone contacts, but with a more intensive follow-up. And of course, some administrative function is working from home. But we have seen some decrease in number of employees working at residential accommodation, and that could be a problem if they don't keep up the contacts we are talking about severe mental ill people living there. If you look at the suspended activities, there's been for the staff meetings are limited by 15 minutes and by number of participants. And sometimes we have gone to stay in different rooms with a video to all who participate in the meetings. There has been a broad information about there's no visits by relatives or friends, both at hospitals and social services. And of course, that has led to some discussions because actually some patients, they discharged themselves from the hospital because they could not have visits of relatives. Then we also have, of course, in the service strategies have made some alternative activities. And what we see is a major digital transformation in the healthcare system and also in the mental health care system. For example, group therapies have been converted to individual and virtual contacts by telephone and video. Outpatients clinics has increased the use of telepsychiatry and psychiatric consultations. And the same goes for actually also the primary care doctors, private psychologists, and psychiatrists. And we have seen just until February month, we have seen video consultation has increased by 1,000% in just the outpatients clinics at the hospitals. Also, some people admitted to the hospital has been actually discharged, but with a change. So that we have more intensive home visits to avoid the hospitalization. And here we're talking about those who has a comorbidity of physical conditions and psychiatry diseases or other major difficulties. And also in those cases, we of course increase the number of telephone contacts, but also physical meetings at homes instead of admitting them to the hospital. We are creating telephone lines both in the region and in municipalities, and also through the volunteers and organizations of patients, organizations of family patients. We have also internally in the hospitals prepared a crisis response in all departments. So, for example, establishments of pure corona isolation bed units in the psychiatry hospital. Right now, we have no COVID-19 affected psychiatry patient at the hospital, but in the case the first person come with a COVID-19 in the hospital, we will automatically make that bed unit a COVID-19 psychiatry bed units. So in that way, try to stop spreading of the infection to both the patients and the professionals working there. And we have also made some strategy. If we have a red, yellow, or green situation, that at one point maybe we will have a plan to of other healthcare personnel as ergotherapists, physiotherapists, psychologists to take over function for care of the patient was usually done by nurses or doctors from psychiatry if they're needed to care for a somatic COVID-19 patient, or if they are sick themselves. So, so there are some crisis plans in this. Yeah, if we look at the issues in the response, I guess there are many places in Europe or in the world there have been a general lack of personal protective equipment, and that has been a big issue also in Denmark. Right now, still in psychiatry, when you go to the hospital, when I go as a doctor in the hospital, I don't wear any mask. Of course, we have alcohol for the hands and keep distances, but as long as the patient doesn't have any symptoms, we just have a little distance and they keep on doing what we normally do. In the beginning, there were not enough COVID-19 testing of healthcare professionals and testing in general. And that was a problem. If you have symptoms, you were sent home, and you have to stay home until your symptoms are gone. And that is a problem in the healthcare system. If many have is home, and maybe just with a normal cough or with a normal influenza or whatever, there's a long time you are at home when you could be needed at hospital. But so far now they have changed it. So if just with mild symptoms, you can get tested now. And we have more testing now in Denmark in general. So now it's not a problem anymore. There's been a big discussion also how to deal with pregnant healthcare professionals in this situation. And there's been a big discussion, also an uncertainty regarding the risk of infection without symptoms when you're working at the hospital. We have also seen in the municipalities that there's been a decrease in home care for elderly, and that could also potentially be a big problem. And of course, there is a potential lack of trained psychiatrists and other mental health professionals to deal with emergency situation. So, there are some issues combined to this. Then also, you can say that it's a very drastic decrease in. We've seen a very drastic decrease in psychiatric hospitalizations as an admission of patients, and also decrease in number of new contacts in the emergency rooms and psychiatric emergency units. And a decrease in number of contacts also in the outpatients clinics. Here we're talking about the visits of known patients. And then we see, of course, a fast change in organization, where in our field of work, it's very important to have a social contact and physical meetings as part of it's a main principle in our work. So it's a big change with this digital transformation. We also see that a family can be isolated with their relatives with mental disorders, and there could be a better help to those people. We also see a misunderstood isolation for more sick people, that they stay home where actually they need to come to the hospital and get admitted or get treatments. And of course, there is a worry about a possible later explosion of people with need of psychiatric help and admission at the hospitals. Yeah. The last slide here is very short, but I have some words on that. I forgot about okay, no, sorry, I forgot about the strengths. Back to that. The strengths here is that we have a basic trust in the Danish welfare model and the government and each other. And the basic trust is also, we call the Danish model, we have more or less an agreement between the employees and the employers to make solutions together. And that's very important in those times. And we have also, people are following the guidelines in a more altruistic point of view to help each other. And there has also been a number of economical help packages to avoid that people get fired from when we are closing things down, that there will be also a time after the crisis. So not all firms and people, they are going bankrupt or people are losing their jobs. So the government is doing a great deal to avoid that. And of course, that's also helped with the stress around that. Yeah. And then we go to the next slides, who is very short, but it will be a little longer what I will say about this. If we look, so my question here is, are we looking at a mental health crisis following the COVID-19 pandemic? And of course, there are some protective factors. As I said before, there's a good economy in Denmark, and there are free healthcare services. There's free welfare and basic secureness. Also, if you're fired from your job, you get compensated for that. And So that will mean that you will maybe have less stress reaction in the public and in the population. There's also clear communication and leadership, and that give a feeling of trust and safe in the population. And as said before, the economical health packages also help towards that aim. We also see that some people with known anxiety disorders feel more normalized in this period of restriction. And people there are some people also in the mental health disorders, they are used to isolation. So now they all see, okay, this is what I do normally. This is the way I live normally. So I can deal with this. But the major parts will mainly be negatively affected by this. And talking about risk factors here, the social isolation is a predictor for failure to thrive. And there was an article in The Lancet in February 2020. I can send you later the link to that. But it deals with the psychological impacts of quarantine and how to reduce it. And the most recent studies reported negative psychological effects of isolation, including post-traumatic stress symptoms, confusion, and anger. And some researchers have also suggested a long-lasting effects of this. Then there's, of course, the risk of losing jobs, and there's radical changes of everyday living and work life. Then there's also the media's role in this, in creating a stress reaction in the population, because there's constantly exposing of themes about COVID-19, and it can be overwhelming for people. Then if you read, there's also after the 9/11 terror attacks in the United States, we saw also in Denmark that it led to stress-related mental health diseases afterwards. So we are affected globally, and by the role of media, also media exposure. Yep. And there was an article in the American Journal of Epidemiology in January 2016 talking about the increased incidence of a rate of trauma and stress-related disorders in Denmark after the September 11, 2001 terrorist attacks in the United States. And it was based on an analysis of 1.4 million contacts with psychiatry services, and they found that the attacks were followed by the immediate 16% increase in the incidence rates of trauma and stress-related disorders. So, saying all this, then we can say, in my point of view, it's only speculation, of course, but in my point of view, we will look into different groups of people who will be affected by this in a mental health care perspective. We have the severe mental health conditions. And here we are looking at a major decrease in contacts right now and admission of people with mental health disorders. And I, of course, have a major concern toward those with long-term severe mental health conditions, the homeless, the psychotic, people who have psychiatric disorders and alcohol and other drug use disorders, the ones who are not able to follow the major digital transformation of the mental health care system. The delayed mental health crisis will come, in my opinion. They will have worsening in their conditions, and before we almost didn't have any capacity to admit severe ill patient in the mental healthcare service. So I'm wondering, where are they now? They are not at the hospitals. Yeah. So maybe it will explode at one point. And therefore, I think it's important to early on address the coming challenges with a delayed mental health crisis of people with severe psychiatric diagnosis. Then we have a second group, the milder mental health conditions. We might see an increase in the new patients in the psychiatric system, the ones who suffer from chronic stress, milder depression, and anxiety disorders will experience an worsening and with increased need of psychiatric help beside what they already maybe have now with the primary care doctors and private psychology sessions. Then we have the mentally healthy population. It will not only be a psychiatric crisis of known patients in the near future, we will experience a mental health crisis in different variants in the world. And the former mentally healthy population will also suffer in the aftermath of the COVID-19 crisis. So what about the healthcare professionals in the front line in the hospitals? What about the group of people who are affected deeply by grief? Because they are losing persons to the infection, to the disease. And what about the huge number of people destroyed financially or gone bankrupt? And in this group, we might also see people with a higher risk of suicidal behavior. I actually asked our professor and expert in this in psychiatry, Merete Nordentoft, about this, about research in suicidal behavior. And right now, of course, we need more time to learn about this, but it is a concern. John, you mentioned it yourself in your email. There's also maybe a fourth group, the children. And I agree with you. And as you said also, there's a fourth group of children who have not been able to play and socialize with friends, and they may have experienced family dysfunction and even violence. That's your words, and I totally agree with that. So we see like four groups of people who will be affected by this, four groups of, so it's going to the end of this, my last question here, what is the strategy? Because we need to raise the focus on mental health. And right now, the focus is on stopping the virus from spreading and infecting the population too fast, so the healthcare system can treat those in need. The focus is also on the economical situation and on the physical conditions. But at the same time, we need to address making a strategy to prevent a rapid increase in people in need of mental health care. A lot of research now in Denmark is going on regarding the hypothesis regarding the COVID-19 effects on mental health. But where is the strategy to avoid and prevent those consequences? The long-term negative effects on the mental health will be expensive, both economical but also in terms of individual human consequences. And the welfare society is a protective factor, but it can also be sacrificed in the prolonged fight against the COVID-19 situation. So I'm afraid that during and after the COVID-19 crisis, we look into a larger mental health crisis, and we need to reach out more and make a national plan for mental health, or even an international plan to prevent a mental health crisis and avoid rapid increase in psychiatric patients to be ahead of things. So we need a plan for prevention and early intervention and treatment responses, and as better yesterday than tomorrow. As ending up this, I know I'm speaking fast, but ending of this, just a little note is that there has been some hypothesis that COVID-19 virus is targeting the central nervous system. It's just a little curiosity. That's maybe the virus is targeting we see that when people are affected with COVID-19, there's a sudden respiratory failure. And maybe it can be explained by the coronavirus ability to attach to ACE2 receptors, and thereby through synaptic spreading to the brainstem. And there have also been patients with subtle loss of sense of smell. And it had made researchers wondering if the virus can spread through the nose cavity to the olfactory epithelium. There's also been reports about COVID-19 related encephalitis. So just a small note in this, that we're talking about the mental health, we're talking about central nervous system and the COVID-19. So we just small notes here in the end. Yeah, that was the end of my speed talk.
Thank you, Mikael. That was comprehensive. I know you didn't cover Finland, but to cover the three countries and give us a very good understanding of the different approaches that are being taken, particularly the differences between Norway, Denmark versus the approach in Sweden. It will be somewhat distressing, I think, to watch over coming months how things continue to evolve in Sweden. Yes, let's wish them well in terms of their strategy. We have a chat facility now available to us, and I'll just lead off with one question from your presentation. And you referred in your prevention strategies to job banks. And I was quite fascinated in what you said there, that essentially it sounds like something, it's a register where people can nominate, look, I'm willing to, come in behind and be a substitute if there are not enough health workers to do jobs. They're being trained. Yes. And I noticed pensioners were part of that group. Is there some sort of screening of those pensioners that are not going to be vulnerable, obviously, to the disease itself, based on what we know? And secondly, are these people remunerated? Are they paid for undertaking that work?
Yeah. For the first question, of course, there will be a screening procedure before people are going into actually working in this. Also, of course, there's a number of those will actually be elderly. So of course, there will be a screening of those who can participate through the job banks. to the answer to the other question is yes, it is paid for even both for students, pensionists, or who comes in and help. It's also open for other kind of healthcare personnel, even psychologists and physiotherapists can participate in this, because it can also just be nurturing the people admitted. But it is paid, and there will be a screening procedure to those who are going to work.
Okay. I have a question from Bill, and it's in relation to the prison population. What's the approach to managing the prison population in relation to COVID generally, and also your forensic mental health, inmates, those that are held under the Mental Health Act in a custodial situation?
Yeah, of course, if you talk about the forensic psychiatry, we also have people for long-term admission there. Yeah. It's the same approach as we do in the other psychiatry units. So, but of course, it's a problem if you are long-term admitted at hospitals. With of course the visit of the relatives is an issue there. But otherwise, it's the normal restrictions we have also in other psychiatry units. I don't have a broad knowledge about what they do in the prisons with the prisons inmates. But so far, I guess they try to keep things as usual, as normal as possible with the contacts. But we have the lack of protective equipment. So of course that's can be an issue. I don't know if I understand the question correctly.
Okay, one of the points you made in your response by the services in adapting to this new situation, less people in acute inpatient settings and intensifying the home visits. I guess I sort of understood that Denmark at least had a fairly low level of hospital beds per 100,000 people. But from your presentation tonight, I got the sense that there is quite a significant inpatient residential component in hospitals. But you've been, decanting, as we say, or lowering the number of people in patients and putting more people into home care. How have staff felt about that? Because you've got a much higher infection rate, than we have in Australia. And even here, there's been some apprehension amongst community mental health workers to going into people's homes with the COVID pandemic. How have you managed that apprehension and sense of anxiety that staff have in relation to that, Mikael?
Yeah. What we see in the municipalities where there's a close connection to home visits, many of those has been converted to telephone contacts. To the first remark you came with, if you compare Denmark to other countries, we have a low number of beds per inhabitants in psychiatry. But now, and there has been a process to even make it lower, so to try to do more outpatient care. That has been the ideology in Denmark. You can agree or disagree with that, because if you look at the time before COVID-19, we had a problem with overloading of inpatients. We didn't have room for enough patients. Sometimes we had to put 2 patients in one room to just keep up. So it's a drastic decrease in the number of inpatients we see now under the COVID-19 crisis. Just in my region, usually we have like minus 30 beds if you register it, and now we have like plus 40 beds in our small region. So it's a major decrease in inpatients, of course, and that's why we try to do something to reach out to them via intensive home care. But okay, and about that, the people, of course, nervous about getting infected. there's been some made some preparation if, of course, people get mentally affected about this. But there's been a big discussion about what about protective equipments? Can we wear masks when we go home to people, or how can we do? What can we do to protect ourselves? And it is a major discussion in Denmark, because in some countries you are wearing masks also in the public. And here, even when you are treating patients and vulnerable patients, and some of them also with somatic diseases, you don't have a mask. So both at the hospital, in the bed units, and at home at patients, right now we are not wearing masks. We are keeping distance. We are using alcohol to wash your hands and all this. But otherwise, it's there's a big discussion. Let's say that about that.
Yeah. Chris Lilly, I've unmuted you, which is probably dangerous. Chris Lilly is almost your equivalent, Mikhail. He even looks a bit the same as you. He's the clinical director here on the Sunshine Coast. So, Chris, are you able to just make you've made a few comments in the chat room there?
Well, John, you don't know the full story at the moment. So, for everybody's benefit, I'm a child and adolescent psychiatrist by training. My substantive role on the Sunshine Coast is, as you say, John, clinical service director for our mental health public service. But John, the bit you don't know is I'm currently sitting as the head of the health service in the lead medical role across all settings. So as a psychiatrist, I've had to learn about things called viruses. I now know a little bit about respiratory illness, and I know what a ventilator is. And in that context, I was really interested in the context of this discussion. Actually, this has been a delightful opportunity for me because I'm a little bit displaced from mental health specifically at the moment. But Mikhail, as you presented today, I thought to myself, if I changed in your presentation Denmark and I wrote Australia, we could be delivering exactly the same conversation. I'll make a couple of comments as well, because one of the things that I've been having to manage across the Sunshine Coast is a realization that we're actually doing, I think, and I hope I'm not tempting fate here, but I think in Australia, particularly Queensland and specifically on the Sunshine Coast, we're doing a very good job. And I think we probably have managed the surge of presentations of COVID, and so far have done that relatively unscathed. And one of the tensions that creates is we've got, like yourself, many beds empty in this facility at the moment, and we're not doing activity because we've got a responsibility to respond to a state-wide prerogative to have capacity to manage the potential for groundswell of activity that it was delightfully and very unpleasantly described in the equivalent presentation last week in Spain, and I was very fearful of that playing through. One of the other things that I'm currently having to manage is some of the tensions that exist around the need to preserve PPE for our clinicians who are very anxious about making sure that they're safe at work. We're trying to work out how we can carefully manage our personal protective equipment. And I have thought that if I were working in a mental health setting at this point in time, with generally the nice weather that we have in Queensland, I probably would be more likely to be meeting somebody in their garden than I would do in their household. And I'd be confident that if I kept 2 meters away from them, I probably could keep myself safe and perhaps wouldn't even bother wearing a mask. So happy to answer any other questions, John, as you want, but I was really taken by how similar your response has been to ours and the relative success that that's demonstrated.
Yeah, thanks, Chris. Chris, you raise a really good point, and you know, both Queensland and South Australia have done a pretty remarkable job in terms of the containment. And like you've just explained, the biggest challenge in South Australia at the moment is we've got within the main COVID hospital, the Royal Adelaide, 200 vacant beds. And of course, how do you redeploy your staff quickly? So we were in the first few weeks of escalating the COVID COSTAT response, putting in the command structures and all those things. We were getting ready to fully operationalize all of that. And now, of course, we've sort of, it's almost like a phony war. It's not there, and yet we've got everything ready to go, and we've got to almost turn the ship again and work out, well, how do we redeploy hundreds of staff gainfully, and do we, you know, ramp up elective surgery again? Do we do other things? We just don't know. And so the next couple of weeks, if the trend continues as is, I think government officials will start to back off on some of the social isolation. We'll then start to see an increase in presentations, but the health system should be able to manage it. But yeah, look, it's a fascinating dynamic to try and manage and respond to, because we have to do this in incredible speed, and we're dealing with very complex, large organisations trying to act very agile in this space. Great to have you on board, and wonderful to hear you doing that job, Chris. Fantastic. Sebastian, I've got a question from you. I'm going to try and unmute you if I can find you. Might be up the top. I can't see you. Sorry, Seb. Oh, there you are. There you are.
G'day. So look, Mikkel, thank you very much for your presentation. I think the question that I originally asked has been answered now about home visits and PPE. I was, however, particularly interested in if you could provide a bit more commentary, please, about the impact on the social services. So in Australia, this is an area which is perhaps underdeveloped, shall we say. And I'd like your comment about the extent to which social services were, how they have been affected, particularly with regards to outreach into people's homes and providing some continuity of support to particularly, I suppose, people with severe mental illness in your service.
Yeah, but the immediate response.
Oh, Mikhail, I think you muted yourself.
Hello?
Sorry, Mikhail. I might have done that accidentally. Hands are here.
Good. Is everyone back? So I can answer?
Yeah, you can answer. That's fine.
Yeah. The immediate response when the COVID-19 crisis arrived was actually that at the residential homes in the social services, people were sent home. The person was sent home. So I had patients in the ER talking to me and coming in and said, we don't have any social services right now. But very fast, they changed that approach, of course, because we have severe ill mental patients living there. So so very fast, they converted and put them back. But still, the number of professionals in the social services are decreased in direct contacts with people with severe mental illness. So it is a difficult situation when you doing everything by the phone, even though you have more intensive and more often telephone calls. The social services is mainly based on physical contacts. It's mentors, it's home helpers, it's helping people doing the daily life, shopping, you know, those things are difficult to do by phone. So we are looking into a big dilemma there, but I know right now that people are still having physical meetings and help in this way, but it's a less degree and less than normal.
Thanks, Seb, and thank you, Mikhail, for that one. I should flag that Sebastian is doing a piece for Croaky, the online health blog, after each of our presentations. So he puts his quill down and writes out a elegant summary of each forum in the style that we're all familiar with from Sebastian. Lewis, I'm going to hand over to you to thank Mikhail and to outline the next seminar and some of the other ones we've got lined up.
Thank you very much, John. Thank you, Mikhail. We have here as one of the persons connected to this webinar, Annette Erlangsen, who is the Danish Research Institute on Suicide Prevention. And as Mikhail mentioned, the possibility of an increase of cases of mental health cases in Denmark after COVID-19 and the possibility of an increase in suicide prevention. I would like to ask Annette what she thinks about that. Annette is working at the same time in Denmark and here in Australia, the Australian National University.
I've just unmuted you, Annette, so.
Right, yeah, I think I'm on now, thank you.
There you are, lovely to see you.
Thanks, Mikkel, it was a really nice presentation you gave and it was completely, I followed it all. Interestingly, I'm now in Australia, but I was in Denmark at the beginning of March, just when the close down happened. So, and I know because I'm employed in the capital region, in Region H, I know from there that there are also many more psychiatric hospital beds empty than usual, and we are discussing whether this is a result. It is a result of the virus, but is it because people are afraid to come to hospital, or is it because they don't sense the same need as earlier? And we are not sure, but as a matter of precaution, we try to act as if it is because they're afraid, because then we want to make sure to support them in any way we can, and reaching out. And here in Australia, I can do the comparison because I've lived in Australia the last couple of years. Here in Australia, there has been a lot more initiatives in online support and online support tools. And I think that would have been really useful to have more of in Denmark right now, but we have them here in Australia. One thing we're going to look into in the coming weeks is actually whether the calls to the National Suicide Hotline, the Lifeline in Denmark, whether they have gone up or not due to the virus, because that's one thing that wouldn't be inhibited of in actual contact. So we'll know more about that in some weeks from now. But for now, we're acting out of precaution. Yeah. But I think as some of the comments here on the chat also was indicating, a lot of the things that are taking place in Denmark are also taking place in Australia. And Australia is about 10 days behind the development that is of the disease progress that is in most of Europe right now, but I see the same measures being installed here. And maybe the Scandinavian countries, they have a benefit of being just about 1/6 of the size of Australia. So you have a much closer top-down movement, things that are being, it's not on state level as here in Australia, it's just directly from the government to the action. That's maybe one of the big differences. But else, I think that the social welfare model is maybe a little bit more progressed in Denmark and in the Scandinavian countries where hardly anyone will have a private health insurance. Here in Australia, many do have that also. But else, they're very comparable. That's all my comments. Thank you.
Thanks, Annette. I think, Mikhail, your call for us to start to focus on the next epidemic, in a sense, the one that's beyond the virus, that's going to attack the mental health of so many groups in our community, is one that you and I have had a bit of conversation about, and you know, Alan Rosen, who's online again tonight, is certainly trying to get a collective response from our governments in this, because we do need to have a strong national approach to this, rather than just simply more money into a few helplines or something that's not really going to be anywhere near adequate nor calibrated, if you like, for the different levels of risk that we will see. But our government, like yours, has taken a very assertive response to trying to protect people's jobs. And just in our parliament yesterday was the biggest ever funding commitment by any Australian government in our history to providing a wage subsidy. And while it's for many people much less than what they would earn, it's a living wage in a sense. It will at least give people some way of bridging across this period while large sections of the economy are shut down. There are still groups that are missing out. Several million people you could identify that aren't getting necessarily access to that support, but it's a very big step forward, and hopefully it'll be improved upon. And we've seen something quite odd in Australia. We haven't seen this for a long time, is very strong collaboration between our unions, government, and big business. So our banks have come to the party in terms of giving people some reprieve around mortgages and payments. We've had the government and the unions working, a conservative government, which has got very little in sort of enduring friendship or respect for the union movement, but they've been working very well, it seems, over the last 2 or 3 weeks to pull this package together. But notwithstanding that, I think your point about there will be many people who lose their businesses, lose their livelihoods, and therefore are at greater risk of suicide and suicidal behaviour. We have then the unknown of all of this. And a friend of mine in Adelaide always says, if you want to give people a mental health problem, you dose them up on uncertainty. And Sebastian, who asked a question a moment ago, he also uses the expression, you know, the enemy of good mental health is isolation. And so we're doing both these things simultaneously to the whole population. And that doesn't happen. I can't think of any other time in my life where this has happened on this scale. It's generally been more a community that's lost its industry or has had some major natural disaster. But here we have a global pandemic, and it's coming to us live every day, and that is going to have a psychologically damaging impact. So I think we really do have to turn our attention very soon to, well, how do we put in place the best possible prevention, early intervention pathways for vast numbers of people who have never sought mental health care but will soon be needing it in large numbers. Thank you, Annette. It was lovely to have you contribute from your dual citizen perspective. Lewis, can I hand to you and we'll close for this evening?
Oh, thank you, John, and thank you, Michael, and everyone for attending this seminar. Sebastian Rosenberg has sent the webpage of CROCI, so everyone who would like to just follow his summaries of these meetings can do that in the webpage. And I would just would like to invite you to our next webinar on Thursday 16th at 5 o'clock in Australian Eastern Standard Time. We will have Deborah Kestel. Deborah Kestel is the Director of the Mental Health and Substance Abuse at the department at the World Health Organization. She was previously the Director of the Pan American Health Organization Department of Mental Health. So she has an incredible understanding of the global perspective. So we are shifting from what is happening in city regions to the strategy and the policy that has been put forward by WHO. Thank you, everyone, and I hope we can meet again on Thursday 16th. Goodbye.